All right, this is video number 2. I'm not going to waste your time. Let's get into it. This is Paeds number 2, and this is shit people get wrong. First thing, everyone knows congenital rubella syndrome. Know all your torch infections, what they do to the baby. You know cardiac cataract, sensory hearing loss. This is what people get wrong. So what I want to point out here is obviously we know that like blueberry muffin rash, yada yada yada. If mom gets infected in the first trimester, that's a problem. Second trimester is like so. Third trimester, if she gets infected, that's no big issue. So this is what it says here. First week to 12 week of gestation, it's highest risk. Then 12 weeks to 20 weeks, low risk, and then greater than 20 weeks, there's no risk at all. How this becomes relevant is in this next slide. If mom comes and like they tell you that like, hey, IgM against rubella is now positive, and she's less than 16 weeks, she's at 12 weeks and now she's worried and she had like a flu-like illness, and you check an IgM against rubella is positive, that's a problem. Her baby has congenital rubella syndrome, tell her to abort. If it's like the 22nd week and she had a flu-like illness, it looked like she had rubella, her IgM is now positive, and her titers before pregnancy were negative, you know she had rubella in that time at the 20th week, that's okay. That's not a problem. So just know this time period. They're going to try to confuse you with this time period. Know the time period. Okay, moving on. Okay. I don't know how to. Okay. I don't know how to get rid of this. Can I? Okay, so this is congenital Zika syndrome, right? This is the one that affects neuroprogenitor cells. The reason I put this in is know all of these things. And the reason I put this here is that infected individuals need barrier contraception. So you're going to tell mom and dad, if they have a history of Zika, to not have sex for 2 to 3 months. So it's kind of a long time. That's just the point I wanted to make. So this is the neuroprogenitor one, and they can have sex for a long time. Okay, moving forward. So this is just a picture to help you remember congenital Zika. Like, look at the brain. It's like microcephaly, and then ventriculomegaly and cortical thinning. Those are like the buzzwords if you want to like go for the buzzwords. Okay, this is neonatal sepsis. Of course, like you'll know neonatal sepsis, like GBS causes an early onset and a late onset neonatal sepsis, whatever. You know all of these. I will assume this is literally a table from UWORLD. What I wanted to add is they're going to ask you for antibiotic therapy. You're going to say ampicillin, gentamicin. Ampicillin will cover listeria. Gentamicin will cover group B strep. E. coli and ampicillin kind of also covers group B strep. You might consider adding acyclovir for HSV, right? That's just what I wanted to add here. Like consider adding that if they haven't given you that. Okay. Next thing, strep throat. Strep throat in adults, we do center criteria. So we do like this. I've written it here. This is not that good in kids, but I put it here anyway. We still use it. If clearly there are viral symptoms, it's a viral sore throat. So supportive care. If there are no viral symptoms, that means is if they don't have itchy eyes, if they don't have like post nasal drip, if they don't have like a drippy nose, right? Those, if they don't have any of that, and then center criteria kind of meets on them, what you're going to do in any case is you're going to rapid strep test them, and you're also going to get a throat culture. If their rapid strep test is positive, you are going to treat for strep throat. If their rapid strep test is negative but their throat culture is positive, you are going to treat for strep throat. The reason, how are you going to treat? You're going to treat with amoxicillin, penicillin. If they're allergic, you're going to give a Zithro. So just point being that you treat kids, but if you think about it, you're never treating kids empirically. So even if like all of center criteria is met, they have exudates, their sister had a sore throat with strep throat, whatever, never treat empirically, right? You will like rapid strep test them, throat culture them. If any one of those two comes back positive, you will treat. Never treat this empirically, even though they're going to try to make you choose empiric treatment. Always confirm, treat with amoxicillin, penicillin, or if allergic, azithromycin. That's all. So infectious mononucleosis, everyone knows all the normal stuff. Just other things to keep in mind. It can cause like airway enlargement, so it can close up your upper airway. In that case, give corticosteroids. There's false negative tests within the first week, and it's associated with the cold IgM autoimmune hemolytic anemia. Next thing, this is just an x-ray just for you to like orient yourself. Again, retropharyngeal abscess, they say that there is an increased prevertebral shadow. So that's this place over here that I'm marking with my pen. This is the epiglottis. Everyone assumes the epiglottis is something coming from like the front to the back. It's actually coming from the back to the front. So like this is the epiglottis right there. You can't see the epiglottis in the second picture. So just know how to orient yourself in these pictures. Okay, so everyone knows croup. Croup is parainfluenza virus or laryngotracheitis, right? It's steeple sign. Everyone knows croup. If you give croup and if they have stridor at rest, you're going to give them nebulized epinephrine and dexamethasone. If they have no stridor at rest, you're just going to give dexamethasone. Now the thing is, right, if you do croup, right, if you do croup and you give them all these things and they're not getting better, or if they have a really high fever, right, so all this stuff here where they look really sick, it can be bacterial tracheitis, and it will also give a steeple sign. It'll look like the same, but that is Staph aureus. So just remember that, like, if you're treating for croup and they're not getting better, it's bacterial tracheitis. Most common cause is Staph aureus, and you cover staph with like Vanco, Nefslan, or something like that. Okay, pertussis. I will assume you know everything already about pertussis. First of all, first thing I want to point out is you post-exposure prophylaxis for pertussis. If they're above regardless of vaccination status, if they're immunocompetent and above the age of 1 month, you're gonna prophylax with erythro, azithro. If they're less than 1 month, you give azithro. You just don't give erythro to babies. That's the only point I want to make. So post-exposure prophylaxis is mandatory regardless of vaccination status. And then the second thing I wanted to point out is we generally think of respiratory isolation for like TB, like the first 2 weeks of TB, yada, yada, yada. You also respiratory isolate for croup, and that's for the first 5 days of antibiotic therapy. This is something just not that many people know. Okay, so acute otitis media complications. Obviously, I will assume you already know that mastoiditis is a complication. Treat mastoiditis if they have like a bulge here, and if they're really like, you'll get the feeling that they have mastoiditis. Treat that empirically, like treat it as a clinical diagnosis. Don't CT scan the temporal bone. The only instance where you're CT scanning the temporal bone if they have a brain abscess. So like if you understand that they have mastoiditis, treat for mastoiditis. CT scan the temporal bone only if they have a brain abscess, so they have increased intracranial pressure, or they have like focal neurological signs, or if you're going in and you're doing a mastoidectomy, then CT the mastoid. But other than that, you really don't need to. Next. Okay, I will assume you already know the varicella zoster post-exposure prophylaxis, where if they're immunocompetent, you give the vaccine, and if they're compromised, you give varicella zoster immune globulin. This is for measles. This is not in UWORLD. If they're between 0 to 6 months, we're going to assume that they're getting the antibody from mom. So it's great, right? If mom is not immune, if mom didn't have titers, then you're going to give them IgG. But if mom had history or whatever, or she had like proper titers, assume that the baby is breastfeeding, assume that they're getting the antibody. So just give IgG. Between 6 to 12 months, that's where it gets tricky. You give IgG plus vaccine. And if they're above 12, like they're normal, they should have gotten the MMR at year 1. So just give the vaccine within 72 hours. And then just IgG. This makes sense. So I'm just going to clear this, take a look at this. This is for measles. And just also remember that measles is airborne precaution and rubella is contact precaution. So the only ones in airborne precautions are varicella, measles, TB, SARS, and COVID. Other stuff is in droplet precautions. So rubella is in droplet precautions. So just another thing to remember. Okay, so if you have tinea of head and toe, remember treat with oral agents. So they're going to get oral like terbinafine or oral griseofulvin. Anything else, any other tinea, you're probably going to be treating with topical. Okay. So here, this is all the bites that you need to know for Step2ck. So cat bites have Pasteurella. So when they get a cat bite, you're worried about Pasteurella. Again, dog bite also has Pasteurella. So what you're going to do is you're going to treat the Pasteurella. You're going to treat the tetanus. And what covers Pasteurella? Amoxicillin clavulanate. So same thing for dog bite. Pasteurella, tetanus, amoxicillin clavulanate. And tetanus immune globulin if you want. So like redo their tetanus. For cat scratch disease, that's Bartonella Hensley. Again, azithro. You're just going to treat with azithro. The reason I put this entire thing up is for this. If they have like a really advanced cat scratch disease, it's kind of a cause of it can cause CNS disease and endocarditis. You're going to add this stuff. This is not super high yield, but like know that you can add rifampin erythrodoxy. And another thing that I wanted to point out is, the Jarisch-Hersheimer reaction, the one that is seen with syphilis, where like you treat for syphilis, the spirochetes like lies, and then the guy gets fevers and chills and you give supportive care. That can also be seen with Bartonella. So that's just another thing to remember. And then last thing is for human bites. Human bites contain anaerobes and Eikenella. Eikenella gives like a bleach-like odor when you put it on agar, and you're going to treat this with amoxicillin clavulanate. Everyone tries to cover anaerobes in like human like bites, and they treat, I don't know, with some random ass shit that covers anaerobes like Clinda or something. Don't do that. Amoxiclav is fine enough. Okay, so if I tell you that there's a kid with bacterial meningitis, clear bacterial meningitis, and he is at 6 weeks of age. The biggest mistake that people do is that they cover listeria. You only cover listeria if they're less than 1 month or if they're greater than 50 years. Anything else, don't cover listeria. So if this kid had bacterial meningitis and he's 6 weeks, so he's greater than 1 month, we're going to give Vanc and Cef and consider Dexa, because now the most common causes of bacterial meningitis in this kitty kiddo are like Neisseria meningitidis, strep pneumo, and Haemophilus influenzae type B. Don't cover listeria if they tell you 5 weeks or 4 weeks and 6 days. Don't do that. Ampicillin is only for less than 1 and above 50. Okay, so this is just less than 1 month. So what do you cover when they're less than 1 month? Obviously, you give third generation Cef, Vanc, and Ampicillin. The reason you're giving third generation Cef, again, in the last video, similarly, try to not give ceftriaxone. Cefotaxime will generally be the correct answer. Ceftriaxone causes kernicterus by displacing albumin. Okay, and then Ampicillin for those like, I will just clear this slide. You can take a look at this. You probably know all of this already. Okay, just bugs for pediatric septic arthritis. If they're really young, assume that it's staph, GBS, or gram negatives. So you're going to give an affinity staphylococcal agent and then gentamicin, cefotaxime. Just the reason this is up here, right, is look at the bugs. The bugs are staph, GBS, staph, GAS, right? So, and look at how we're treating. In one we're giving gentamicin, and the other where there is no gentamicin because we're not worried about GBS. Contrast this, the reason that this is up, right, is you contrast the bugs of pediatric septic arthritis with pediatric osteomyelitis, which is this. So do you see how this is like super varied? Like less than 2 months is GBS E. coli. You could have guessed that. 2 months to 4 years, this Kingella kingae. This is the only place I've seen this in Step2ck. Such a weird bug. So they could easily give you a kid who's like 12 months and ask you what is the cause of his osteomyelitis. Kingella kingae. So this is a weird one. Above 4 years, Staph aureus, you could have guessed that as well. And sickle cell disease, salmonella, you probably already knew that. So just contrast this with the bugs for septic arthritis, and the osteomyelitis bugs are different. There's a new one, Kingella kingae. So just focus on that. Okay, this is just quick infectious disease review. Norovirus, rotavirus, supportive, enteropathogenic E. coli, supportive, enterotoxigenic E. coli, supportive, enterohemorrhagic E. coli, supportive. This, if you give antimicrobial therapy, you increase the risk of hemolytic uremic syndrome. Salmonella, so you treat, in some instances, treating salmonella. So salmonella enteritis, you don't treat. Salmonella typhoid fever, you do treat. You treat that with either Cef or fluoroquinolone. Shigella, you do treat with TMP SMX. This, if you treat, you decrease the risk of hemolytic uremic syndrome. Campylobacter, there's a table in UWORLD about when you treat this. You only treat this when symptoms are more than like either 7 or 10 days, or there's a high fever, or they're immunocompromised. But generally, Campylobacter, or if there's blood in the stool, so like know that table. I have forgotten it right now, but know that table. Okay. So Lyme obviously can cause arthritis. There's early localized Lyme, there's early disseminated Lyme, and then there's late disseminated Lyme. Early localized Lyme will cause an oligoarticular arthritis. That means less than 4 joints involved. The reason I put this up is Lyme can cause many different arthritises. So have like a high, like, don't rule anything, like based on the pattern of the arthritis, don't rule anything out. Early disseminated Lyme, so that can cause multiple erythema migrans, migratory arthralgia, so kind of like lupus, like. And then late disseminated can cause a chronic arthritis, an acute monoarticular arthritis, and asymmetric oligoarthritis. The point is, for putting this up here, is Lyme can cause many different patterns of arthritis, and maybe if you want to memorize them. Another thing that I'd like to point out about Lyme, okay, I think I have a slide for it. So if I told you that some person clearly has Lyme, he has like a history of Lyme, and now he has bilateral Bell's palsy or even unilateral Bell's palsy, and we ask for treatment, a majority of people pick ceftriaxone, thinking that this is CNS Lyme. The thing is, right, if you have facial nerve paralysis because of Lyme's disease, the facial nerve is a peripheral nerve. Peripheral Lyme is treated with doxycycline. So only give ceftriaxone for cardiac Lyme or CNS like encephalitis. So only for the AV block and for the encephalitis. Anything else gets doxycycline. Facial nerve paralysis, that's a peripheral nerve. That gets doxycycline, right? Then Lyme is transmitted by Ixodes scapularis. Remember that there are 3 diseases with that. There's anaplasmosis, babesiosis, and Lyme's disease. Know how to recognize that tick and know that those 5 things required for prophylaxis. And prophylaxis is once oral doxycycline, and treatment is doxycycline for 14 days. And another thing that I like to point out here is Lyme disease obviously treated by doxycycline. Some people you can't give doxycycline, true, so you're going to give amoxicillin. Okay, and if you're going to give amoxicillin or cefuroxime, that's what you're going to do. Those are like pregnant and people less than 8 years. Okay, moving on. This is the 5 criteria for Lyme disease prevention. If all 5 aren't met, you're not going to prophylax. Oh, also another point is suppose all 5 criteria are met and they tell you that they're allergic to doxycycline. What are you going to do? So the answer in that case is do nothing. You can check this on UpToDate, but in cases where they're allergic to doxycycline, you do nothing for prophylaxis for asymptomatic patients. You do treat if they have actual Lyme, but if they have Lyme, like they came and they have a tick and you're preventing Lyme and they're allergic to doxycycline, which is the thing we wanted to give, do nothing. Okay, move on. Okay, so this is just if they have acute rheumatic fever, obviously you will recognize from the stem. Just remember this. People kind of forget this. You can pause the video and take a look at it yourself. And remember also this: that intramuscular penicillin G for every 3, like weekly. They get it weekly for 3 to 4, or like every 3 to 4 weeks they get like a dose. So just remember how it's given, right? It's like it's an injection. Okay, I wanted to point this out. Look, native valve endocarditis, prosthetic valve endocarditis. I'm not going to go into the detail of what like prophylaxis to give. What I wanted to point out is that in prosthetic valve endocarditis, if it's less than 1 year from valve replacement, you're adding gentamicin and rifampin. So vanc and cefepime you could have guessed. But if it's less than 1 year since their prosthetic valve was upright, you're going to cover with gentamicin and rifampin. That is just like a new thing. Everything else I will assume you already have some idea of. And then remember the HASIC group. Like we know how to cover staph. We'll give vancomycin, then check it whether if it's MSSA, MRSA. Then we'll like decide nafcillin, vancomycin, whatever. But like HASIC group, the weird ones from first aid, how do you treat those? What if they tell you it's a HASIC group endocarditis? Just give cephalosporins, right? So cephalosporins, you can like that's a weird one, but you just memorize it. Okay, so things that prolong QT interval, right? So QT is prolonged by a bunch of things. Obviously, decrease of all the electrolytes, hypokalemia, hypomagnesemia, hypocalcemia, all prolong QT. This is just the drugs that do it. In this, opioids are a big cause inpatient. Sotalol is like a big cause, and all these other ones. I just want to focus on this sotalol. The thing about sotalol is, right, sotalol prolongs QT so much that you have to start this inpatient. You can't send someone home on sotalol, that's going to kill them. And another thing is then there are those congenital long QT syndromes. So Givier, Lang, Nielsen, whatever, and Romano-Ward. Romano-Ward is autosomal dominant. The other one is autosomal recessive. And the autosomal recessive one, because remember, recessive diseases generally mess you up more. So that's the one associated with sensorineural hearing loss. How you treat these is you give a beta blocker. So that's like you know how like for hypertrophic obstructive cardiomyopathy, how we treat is like beta blocker, calcium channel blocker, increased preload. So for this, similarly, you give a beta blocker, but just notice that not sotalol though, because sotalol prolongs QT. You give any other beta blocker like metoprolol or something like that. Anyways, moving on. So just know what a Stokes-Adams attack is. Whenever you have like a Stokes-Adams attack, right, is when you have syncope of generally unknown cause or presumed cardiac cause. So a Stokes-Adams attack is like you're minding your own business. You know how in vasovagal syncope, there's like a prodrome. You feel like blood rushing to your feet, or you feel like a feeling of warmth, and you pass out. That's vasovagal. If you pass out, like as is, if I'm walking, I'm talking. If I pass out right now, talking to you guys, that's a Stokes-Adams attack. That is a clue for cardiac etiology. So cardiac etiology, they're going to pass out like cold, nothing. They're going to pass out. They're going to get back up. So that's a Stokes-Adams attack, a paroxysmal sudden loss of consciousness, generally associated with cardiac causes and generally third degree heart block. Okay, so bad murmurs. Know your bad murmurs. Everyone on UWORLD gets this wrong. I don't know why. Like, just know your bad murmurs. Holosystolic is bad. Diastolic is bad. Harsh is bad. Greater than grade 3 intensity is bad. I'm not going to read this out to you. Just read this on your own. Just know which murmurs are bad. And remember, and know what a venous hum is. And know that venous hums are okay. Okay. So kid comes in, kid has a UTI, kid is like kid is like maybe 6 months old. He doesn't wear diapers. His parents don't like diapers. So, and he has like UTI symptoms. Kid doesn't tell you, but they're going to tell you the kid is fussy and whatever, and he has a fever. So obviously you're going to suspect like a UTI in this kid. For kids who don't wear diapers, right? You're gonna get a midstream clean catch urine sample. You're gonna have them pee. They're gonna pee, 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 pee. You're gonna get your thing. You're gonna catch the urine. So that's for kids who don't wear diapers. If they wear a diaper, right? It's weird, but if they wear a diaper, you straight catheterize them. That's weird. I don't know if you guys would want this happening to your kid, but this is what you do. You catheterize these babies. So if they do not wear diapers, midstream urine. If they wear diapers, catheterize them and get the sample, and then like treat the UTI as is. Okay. Okay. Indications for renal bladder ultrasound. Just revise these right here. Just pause the video. I'm not going to read them to you, but they're right there. So this is for renal bladder ultrasound. If you kind of think about it, there's a very low threshold for renal and bladder ultrasounding them. And then just another thing that I'd like to point out is don't bladder ultrasound them when they're in the UTI. Treat the UTI, wait a week or so, bladder ultrasound them to look for like shit then. So just wait, like delayed ultrasound, which is similar like idea is true in like diverticulitis, like late colonoscopy, them in like 4 to 6 weeks. This is like a similar idea there. Anyways, moving on. So vesico-urethral reflux. This is this voiding cystourethrogram. I'm sorry I put VUR here. That's not what I meant. These are the indications for that. So if they're less than 2, they have recurrent UTIs. If they're less than 1 month, that is just weird. If they have a UTI, and then because like remember, you're never going to empirically treat, but you're always going to get a culture from these kids. And if the culture comes back anything other than E. coli, like Klebsiella, any other weird shit, you're gonna like vesico-cystourethrogram these guys. That is an indication. Okay. If the kid's really fat, right, and they tell you that sometimes he has proteinuria 1 plus, and then he came to the office some other day and he had 2 plus, and then he came to the office some other day and then he had 1 plus again, and then sometimes maybe his protein is like, and he looks fine. He looks fine, but he's really fat. That's okay. It's orthostatic proteinuria. Or if someone has been standing for a long time, so if he tells you that he's like a cashier or something, orthostatic proteinuria is normal. It can happen in adolescents, and it just especially happens in fat kids. You can read the text that I've written here. Okay, febrile seizures. The reason I put this up is I just want to point out that focal seizures are considered complex febrile seizures. Focal seizures are bad. Generally, a normal febrile seizure should be generalized. So it should be tonic-clonic. So that's just the only thing I wanted to point out, that it's kind of like the other way around. Like a generalized seizure in this case is better than a focal seizure. Okay, this is the NAMBOS question that everyone gets wrong. I've taken this straight from NAMBOS, like sue me, I don't know. But if the guy, just read this text is like some kid is like playing and he knocks out, like he breaks off his tooth, and they ask you what to do, and everyone gets this wrong. Just what you do is, it's kind of weird. What you do is you get the tooth, you clean it with normal water, and you put it back. You put it back where it is. You don't scrape the tooth. You don't aggressively brush your teeth. You don't do any of that. You just put the tooth back in its socket, right? Or if you want to store the tooth, you store it in milk or hand, like this thing, Hank's balanced solution, right? Or cold milk, right? Do not store in tap water. If the person, similarly, like if someone cuts off their finger or some shit, you tell them to put their finger in like a plastic bag thing, put that in water, and then fill it with ice. Don't put shit directly on ice. Anyway, same idea kind of here. So next. Okay, gastroschisis and omphalocele. With omphalocele, remember that omphalocele, first of all, it's associated with Patau syndrome. Then second of all, it's associated with like Beckwith-Wiedemann. It's associated with like trisomies. Gastroschisis is like the and then omphalocele is covered with like the umbilical like membrane or whatever. But remember that like if you think about it, omphalocele is covered by the like whatever, there is the membrane. I forgot the membrane, but it's covered by that membrane. And if anything, it's an easier fix. You just push things back, but it's associated with underlying chromosomal abnormalities. Gastroschisis, on the other hand, is like when your intestines are out there floating in amniotic fluid. There's a complete defect. And gastroschisis is generally not associated with any chromosomal underlying abnormalities. If there is one complication for gastroschisis, it's intestinal dysmotility. The amniotic fluid, right, just really irritates the open bowel that's in it. And generally, this is like, you can read the text here. Okay. If a child is exposed to TB under the age of 5, right? If it's a known exposure, so he went to see his grandparents and his grandparents had TB and they have known TB, and you come back and you PPD this kid, his PPD comes back fine, 17, 22, whatever, right? You're going to treat him. And you chest x-ray him and his x-ray looks fine as well. You are going to treat, right? Just the thing that they're saying here, that children less than 5 years have fucked up immune systems. When they have fucked up immune systems, they give a false negative tuberculin skin test and they progress to latent TB. Just, and also know that like what the cutoff is. Everyone knows like the main cutoffs for 5, 10, 15, but like I would urge you to go and look at them again. The cutoff for 5 is if you have had known contact with the TB case, your cutoff is 5 now. If it's within the last like 5 years that you've come from an endemic region, I just immigrated to the United States from Pakistan, my cutoff is 10. If you have diabetes, your cutoff is 10. So make sure you know those cutoffs. But yeah, because those cutoff, like focus on the ones that you don't know, that don't automatically come to mind. Okay, that's all for his. Okay, that's it, guys. Peace.